All right, we're going to start with Ober's test. This is for the IT band, and you can face that way. So again, that IT band, the patient may have pain along in here. And have we already done Ober's test? We did, didn't we? We did. I'm going to do it again. So Ober's, you can extend that leg just a little bit past the straight line, and then we're going to straighten that leg while supporting the pelvis from tilting, and see if Andrew's leg has an easy time touching the table, and it does. If he had a lot of IT band tightness, he might, his leg might hover there, or he might start complaining of a lot of pain, but usually just looking for restricted motion there too, okay? We're moving on to the knee test. Andrew, why don't you just lay on your back here? So we have a couple of tests for the knee, valgus and varus stress. So a valgus stress, I'm going to be facing Andrew's opposite pelvis, and I'm going to be putting my hand through, kind of pushing perpendicular through his joint line, and I'm just going to be adding a force there, mainly looking just for excessive hinging and gapping and motion across that medial collateral ligament. He may or may not have pain, so we're really just trying to feel for that motion, see if it locks or if it feels really rubbery at that point. The other version, the varus test, stresses primarily the lateral collateral, and I'll be facing Andrew's opposite foot. I'm pushing perpendicular through his knee towards my pelvis and looking for excessive motion through that joint, and those felt very stable. Next one, we do the anterior and posterior drawer. Anterior drawer, we're going to bend the leg to about a 90-degree bend right here. I can sit on his leg just to support it, and I'm going to grab the back of his calf, popliteal fossa, and I'm going to be pulling towards me. Pretty solid. These are strong ligaments. A lot of times these things are pain-free even when they're injured, if they're out of the acute phase. And if his leg is swollen like this, it's going to be hard to evaluate anyway. So usually this would be a subclinical. He's had pain here for a couple of weeks. Let's test and see if he has an ACL tear. So I'm trying to look for excessive motion of that tibia coming forward. He has a nice stop at the end. He may move a little bit, but then he should hit a wall as far as kind of, that rubberiness sort of hits a wall. And that's testing the ACL. We're pulling anteriorly on the tibia. I'm in an anterior drawer, testing the anterior cruciate ligament, all right? The opposite, posterior drawer, we're pushing opposite. I'm just pushing, kind of putting my contact at the thenar eminence there, and then just pushing towards Andrew's buttocks along the line of his femur, and I'm looking for excessive motion going posteriorly that might indicate a posterior cruciate ligament injury, all right? Lockman's is testing similarly to the anterior drawer, though it's a little bit different position. It's more like 30 degrees off of the horizon right there. It's a little bit lower. I'm essentially doing the same thing. I'm going to be pulling the tibia towards me, looking for excessive motion. And not seeing a whole lot there. I'm essentially kind of doing that, if you couldn't tell, but looking for that excess sliding forward. It's thought to be a little bit more specific than the anterior drawer, and again, it's testing the anterior cruciate ligament. Next one, we have some tests for the meniscus, McMurray's and Apley's compression. So McMurray's has two components. One is a kind of a valgus component, if you want to think about that. So I'm going to grab Andrew's leg. I'm going to actually externally rotate a little bit towards me. So I'm just pulling his tibia towards me. And I'm going to be contacting throughout this perpendicular through his knee. And so as I do this test, I'm pushing his knee lateral to medial while I'm extending his knee. And I'm looking for a catch. I'm looking for a click. So we can do that again. Starting flexed, external rotate, and just push that leg, looking for a little catch or click. It may not be painful again. This may be something out of the subacute phase. We're really just looking for that grinding catch. And that's a little bit more for the lateral collateral ligament. Because you can imagine that valgus force, if we're pushing through there, we're actually opening up the medial compartment and we're compressing more of the lateral compartment. So we're going to kind of catch that lateral meniscus. We can also do a varus form of McMurray's, kind of facing his opposite foot. I'm going to internally rotate, and we're just going to let his thigh kind of naturally, it wants to externally rotate, and I'm just going to be pushing while I extend his leg. I'm doing that same thing, looking for a click, crunch as we're doing that. All right? We also have Apley's compression. Andrew, why don't you go face down here for me? This one, another meniscus test. I'm just going to bend Andrew's leg, and I'm just going to be feeling at his popliteal fossa, not really doing much there other than just feeling for a click while I'm also listening for it. And we're adding a load with my other hand, pushing down, and then I'm going to be loading clockwise and then trying to load counterclockwise and looking for a grinding, gristly noise that could indicate the meniscus is injured. Why don't you face the ceiling here for me? So the next one is the sweep test. And with the sweep test, we're looking for an effusion. So we're looking for lumps and bumps around Andrew's knee, and we're trying to push that lump and see if we get a new lump appear over here. And if we can sweep through that lump, maybe we'll see that there's a new lump that appears here. And we're kind of sloshing fluid around in this pretty large compartment. He has absolutely no effusion, so it's hard to see, but that's kind of where it gets its name, trying to kind of sweep that fluid and get it to move away or disappear. And I'm just kind of using the back of my intermediate phalanges right there, middle phalanges. All right. Next one, patella baja, patella alta. We've got the length of the patella, and then we've got the tibial tuberosity. So right now, we can measure this. I'm just eyeballing it, and so I'm kind of comparing this length, the length of the patella, to the length of the distance between the inferior pole to the tibial tuberosity. And those all look pretty equal to me. If we did something like this, you can see that the distance here is a lot longer than the distance of the patella. And that would indicate a high riding patella, a patella alta, which might make for more potential compressive forces as he bends his knee and more chondromalacia patella, degeneration of the joint cartilage. The opposite, if we measured something like this and he had a short, relatively shorter patellar ligament and a shorter distance between the inferior pole to the tibial tuberosity, that would be a patella baja, right? And that could make for a little bit more tendency of that patella to move around. Sorry, I think I had those backwards. Dang it. So the longer the ligament is, the more potential sloppiness that patella is going to have. The shorter that ligament is, the more compressive force it's going to have. So I think I said that backwards, all right? So if we have a shorter relative tendon, there's more compressive forces, less wiggliness, less play room in that area, right? If it's a longer tendon, there's more sloppiness and a tendency for that patella to subluxate or potentially dislocate too. So sometimes people do that when they're running, that patella will, slide out of track and come off. So this can help you determine that. Sorry for that on the video. Moving on to the ankle, we have inversion and eversion testing. So here, we can evert the foot. We're just going to compare side to side. We're everting and we're stretching that medial or deltoid ligament, looking for excessive motion. And again, this is one of those tests that you just have to compare side to side. We can also do the inversion test, where we're just going to take that ankle and we are then inverting and looking for excessive inversion compared to the other ankle. We can also palpate just inferior to the medial malleolus. That's going to be the calcaneofibular ligament, if you had tenderness right there. If we move just a little bit in front of that, this is going to be the talofibular ligament, tenderness right there, anterior talofibular ligament, and then just a little bit behind it right there, if you had tenderness, is the posterior talofibular ligament. So we can sometimes isolate which individual ligament may have been strained by just palpating and feeling it, and we may want to direct therapies where his maximal tenderness is in doing that. We also have the anterior and posterior drawer test. Andrew, I'm going to scoot you down this way just a half foot. There we go. So anterior drawer, you could do it while he's prone or supine. I'm just going to grab that ankle and I'm just going to be stabilizing his tibia, and I'm really just pulling up towards the ceiling, trying to look for excessive sloppiness, excessive motion in one ankle compared to the other. And it could be the deltoid, it could be those lateral ligaments that are sprained, it could be the capsule itself, but it can give us an indication of stability in that ankle by doing the anterior drawer. And then likewise, we can also push inferiorly and do the posterior drawer. It's kind of the same thing. I'm just pushing down with my hand while stabilizing the tibia, all right? Very similar to the knee tests. We also have the Thompson test. Why don't you go face down for me, Andrew? The Thompson test We're gonna have our patients just feet off the edge of the table. Andrew. And I'm just gonna be squeezing the calf, and I'm looking for plantar flexion, right? In Andrew, he's got a really lean, narrow ankle. It's really easy to see these tendons, but sometimes if people have an enlarged ankle, it's hard to see the anatomy, or it's very swollen. This might be a test that's helpful to see. Does that Achilles tendon actually attach to the soleus and gastrocnemius, or is there a potential rupture of that tendon? So it's an easy test to look for tendon integrity. And then last but not least, Andrew, when I have you sit up here a second for me, or can you sit with one of your legs kind of almost perfect? Zoom in here. Okay, for the phi line, we're comparing the inferior pole of his medial malleolus, and we're going to draw a line straight to the apex of that first metatarsophalangeal joint. So we have a line running there, and I use a pin to do it. And then we're going to feel for that navicular tuberosity, which is right there. And so it looks like that's pretty much right in line. I should have a pin. Can I draw it in? Oh my God, 1 second. Okay, so just kind of the inferior border right there, the apex, I could use a straight line. And then I'm going to feel for that navicular tuberosity, which is really pretty much right there. So that's what we want. That looks like a nice, we should expect that with a normal arch. We're also going to compare when he stands up to see if that line gets dragged downward, so he has kind of a functional pronation. If we're checking him out right now and that navicular tuberosity is already down low, he may already have been born kind of with a congenital flat foot, and so his foot architecturally is already flat. But now it looks normal. Let's see if it changes to a functional pronation when he stands up. Andrew, why don't you stand up here? And that looks pretty much the same. It hasn't really drooped considerably. And then Andrew, if you want, why don't you face that way? Another thing that we can look for with this, we talked about, was kind of the lateral drift of the Achilles tendon. If you see it come down, it looks pretty straight here on Andrew, looks nice. But if we start to see it really drift to the outside, almost form like a backwards L, we would see that and could indicate that there's a pronation of the foot.